clinical uses. Again, those are my disclosures, and the objectives of this talk is to discuss the concept and mechanism of action of cryoablation. We'll discuss the application of cryoablation in both acute and the chronic pain world. We'll also talk about clinical evidence, efficacy of cryo, and the treatment of different pain conditions. And at the end, I'll have small clinical case reports, scenarios from my practice about cryo cases. So when we define cryoablation, there is certain terms that we can use it interchangeably. You can call it cryoablation when you use it for pain, as that what application started in 1976. We call cryoanalgesia, or also you can call it cryoneurolysis if you're specifically freezing a nerve. And we all know there is three main non-surgical modalities that can use to ablate the nervous system. You have the cryoablation, which application of extreme cold to the nervous tissue. We have radiofrequency ablation, or RFA, which we use very commonly, which application of high temperature, usually 80 degrees, sometimes a little less. And we have the chemical neurolysis, such as using of alcohol and phenol. We use that a lot in cancer pain, for example, for celiac plexus neurolysis and other modalities as well. So when we talk about warm or cold, well, we use a lot of radiofrequency ablation. Typical radiofrequency ablation, whether used conventional, usually anywhere between 60 degrees for cooled RFA, for example. And a lot of people are confused about cooled RFA because it's not really cool. It's 60 degrees still, but it's relatively cooled compared to the conventional, which is usually 80 degrees. And you can use pulsed RF, usually temperature is plus 42 to plus 48 Celsius. While cryoanalgesia is application of very low temperature, anywhere between negative 20 Celsius up to down to negative 50 Celsius. So the application of cryoablation, cryoneurolysis, is application of extreme cold to destroy targeted tissue, which could be a tumor, for example. It could be a targeted nerve. In this case, we call it cryoneurolysis. While cryoablation can target other tissues, such as a tumor, we used for other indication than pain management. So when we talk about history here, so in 1961, Cooper was the first who described the first cryoprobe for cryolesioning. As you can see here, you can see there is an exhaust and the nitrous oxide, and it goes through silver probe tip, and through this tip you have the cold gas and the formation of ice ball using a cool low temperature gas out, and you can see that in that picture. In 1976, it was Lloyd has described the first term, or when he used the term cryoanalgesia for pain management, and he proved that this can be used safely, better than surgical resection of the nerve. So when you talk about cryophysics, you have a compressed gas, either CO2 or nitrous oxide, and those compressed gas, sometimes you have this huge tank, and this compressed gas is released through the small openings that you can see here in the drawing, in a tiny opening, and expands to the tip. It goes to negative 70 Celsius, and in the tissues, when it's delivered, it's around negative 20 to negative 45 Celsius, as you can see here in the small drawing. And when we see the cryolesion here, as you can see the ice ball, what we call, after 90 seconds, and this really usually the size of the ice ball, it really has different factors, but at the end it can reach up to even 14 millimeter, depending on the size of the probe and what type or active tip of the probe, how it looks like. So how cryoanalgesia works? Cryo, cold temperature, usually around negative 70, that starts, and as I said, when it reaches to the tissues around negative 40 to negative 45, it creates a conduction block, which is very similar to the effect of local anesthetic. And the long-term pain relief from freezing those nerves occurs because the ice crystals create on a cellular level vascular damage to the vasa nervorum, and all this leads to production of severe inside the nerve endoneurial edema. And cryoanalgesia disrupts the nerve structure, and I will explain that in details in the next slide. It creates Wallerian degeneration, which is reversible axonal destruction. And the Wallerian degeneration involves both axon and myelin, but it preserves the endoneurium, perineurium, and other layers. And what happens is the Wallerian degeneration happens distal to the ablating lesion, and it induces that block lasts until axonal regeneration occur. It lasts until regeneration of the axon starts. Typically, it starts at the rate of 1 to 2 millimeters per day. And typically, when the complete regeneration happens and conduction comes back to normal, then when cryoanalgesia the effect of analgesia start waning or decreasing. So once the axon have regenerated, it connects with the sensory receptors again, and the conduction start again, and the regrowth of those axons into the perineurium eventually restores sensation, and eventually the block functionally resolves, and the pain recurs again. And this is an important slide. This is describe the nerve injury, and this is very applicable to what I'll be describing here. So when you have as you can see here, the layers, the cell body, the axons, the myelin sheath, and in yellow, you can see the axon, the myelin sheath around it, and the layers, the endoneurium, epineurium, perineurium. And this is normal, as you can see, if you can divide it up from above and below. The first degree nerve injury to the left, as you can see here in the drawing, you have an injury of the myelin sheath. However, other layers such as the axons, the endo, peri, and epineurium are intact in the first degree, what we call neuropraxia. And what happens is you have a conduction block when this happens, and you expect from this in the first degree nerve injury a complete recovery. We see that a lot when you see positional injury for prolonged anesthesia. It can happen to the ulnar nerve, for example, or for the common peroneal nerve, the nerve that are vulnerable and superficial and can be prone to position-related injury. This is typically happen what we call neuropraxia. And usually we reassure those patients that after a few months, you expect complete recovery. So that's the first degree neuropraxia, affecting only the myelin sheath. While the second degree neuropraxia here, so again, infiltration block, or when you give local anesthetic, what happens is you have conduction block. And you cause injury, or you cause conduction block and affection of the myelin sheath without affecting other layers. When you do cryoanalgesia, as you can see in this arrow, you called what you call axonotmesis. And axonotmesis is a second degree nerve injury. And as you can see in the drawing, you have affection to the axon in addition to the myelin sheath. So the axon is destroyed, the myelin sheath is destroyed. And what's the difference between that and the local anesthetic infiltration, or what happened when you have a first degree neuropraxia, is that you have Wallerian degeneration, not just conduction block, but you have a Wallerian degeneration. And also, like the first degree, you expect complete recovery when you do cryoanalgesia at -45 degrees Celsius. Well, when you have a surgical resection of the nerve, or when you have a very low temperature, freezing below -100 Celsius, that when you have neurotmesis. And neurotmesis is a third degree, fourth degree, or fifth degree nerve injuries. And for those cases, you have extension of the endoneurium for the third degree. In addition to that, you have for the third degree, the perineurium, and at the fifth degree, you have everything. You have the myelin sheath, the axon, and all other layers. What happens for those cases, like what happened in cryo, in terms there is a Wallerian degeneration, but unfortunately, you have incomplete recovery, unlike cryoanalgesia. So this is histologically the untreated tissue on the left, and 1 week post-treatment, and you clearly can see that histologically the Wallerian degeneration or the changes that happen inside the cell. So as you can see in those drawings, the nerve regeneration occurs immediately at a rate of 1 to 2 millimeters per day within the intact endoneural tube, and it occurs from the point of injury distally. So as you can see in the second line, the second drawing, the cryo probe here and that's the snowball or the subcrystal, and distal to that, you have the axonotmesis, as I explained, distal to it. As the time passes, the histology remains normal, but slower nerve conduction velocity persists. So it starts regenerating here. And the last drawing, this is after 6 months, you have complete regeneration. So sometimes even if histologically it becomes normal, slower nerve conduction velocity persists from 35 up to several months after the new myelin sheath are fully formed. That's why we see some cases lasting even beyond that. So when you talk about the effectiveness of cryo lesion, it depending on the several factors. One is the freezing temperature, distance between the probe and the nerve. That's why you can use ultrasound or X-ray, or you can combine both for these cases. As I will show you later, there's different types of probes. The dimension of the cryo probe plays a role in it. The dimension of the ice ball, how big it is or how small it is, and the temperature inside the tissue during the freezing, which means circulation of blood. In terms of indication, there is plenty of indication for cryoneurolysis. Just to name a few is post-thoracotomy chest wall pain, intercostal neuralgia. We did cases for example, Pancoast tumor, when patients have infiltration of the intercostal nerve from the tumor, infecting the upper part of the lung. And we use the cryoablation using combined ultrasound X-ray technique, can be very effective. Recently, I did a few cases with thoracic surgery for cases that expect post-thoracotomy syndrome. So we do it preemptively, intraoperatively with a special probe, and we ablate those intercostal nerves for post-operative analgesia. Other indications such as facial pain syndromes, small cases, for occipital neuralgia, for example, if they respond for short term for occipital blocks, we can do that. Neuromas can be very effective. Neuropathy, such as peroneal neuropathy, cancer pain, as I explained, can use it for spine, SI joint dysfunction, lumbar facet syndrome, foot pain due to neuromas. We can use it for painful shoulders, knee and hips. You can ablate the articular branches or suprascapular nerve. For coccydynia, for pelvic pain, as the case that I will show you later. I'm not going to go through all the studies, but there is certain study that's been described for acute and for chronic pain. For the cryoablation for acute postoperative pain, there's 4 main studies for post-thoracotomy syndrome, and the 3 main studies for post-knee arthroplasty. Those are the big ones. While for post-mastectomy and for shoulder arthroplasty, those studies were mostly small sample size case reports, and most of the studies shows positive results. While for cryoablation of chronic pain, there is again few studies. This is the same one we explained for knee arthroplasty, but the other studies for TMJ, for example, for refractory peripheral neuropathy, for sural neuroma, phantom limb pain, myalgia parastatica, and other indications. So when you're talking about risks and contraindication, like any procedure, you have risk of bleeding, bruising, infection. You have the risk of skin hyperpigmentation or alopecia, especially if you're ablating a superficial structure such as supraorbital nerve. You have to be careful. You can have possible neuropathic pain. Again, there is, for example, for intercostal nerve, there was been 3 studies that shows that. However, there is other studies that were negative. You can have motor weakness if a mixed nerve is targeted. That's why for those cases, you measure risk-benefit ratio and see if it's worth it or not. For example, if you have a case, post-stroke pain, when they have severe shoulder pain, you have suprascapular nerve, which is a mixed nerve. In that case, sometimes you don't care too much about the motor restoration, but rather you want to ablate that or freeze that nerve, knowing to cause the pain relief, because you don't care too much about supraspinatus weakness at that point. And there is no published report of neuromas following cryoablation. So this is kind of a small way or a small diagram to see how you can think about it. First, you want to see if you can identify this nerve by advanced imaging. And if you do, then if it's yes, you can see it. Does the nerve carry motor fibers or not? So if you can see it by imaging, by ultrasound, and it does not carry motor nerve fibers, then you proceed with a cryoablation of the targeted nerve. If you can locate the nerve, but the nerve has motor fibers, then you evaluate, as I say, the benefits of cryo versus the risk of paralysis, and you weigh it. What if you cannot locate that using imaging? You can do nerve stimulation with local anesthetic to identify the nerve locus. And if you can, then you proceed with the cryoablation. If you cannot, then you seek alternative techniques. There is different probes, there is different systems. This is one of the systems, but there's the probe that, are 21 gauge with length 20 millimeter needle tip. And there is one that have longer 90 millimeter needle tip. And the freezing tip for those cases is around 5 millimeter. There is other probes that are longer, 9 or, this is the 21 gauge, again, 9 or 2 centimeter long. And you can see that after 1 minute, it reaches 5 millimeter and can reach up to 8 millimeter in diameter. This is a bigger one, about 12 centimeter, 120 millimeter radius or trocar tip. As you can see, the tip are different than the other one. And the tip, it can give 8 millimeter for the radius. And if you wait for 2 minutes, the trocar tip can give up to 10 millimeter radius, while the other one, the R tip, the radius tip, can give up to 13 millimeter. Why is this important? Because again, depending on your target, you need to plan. If you're going deep, for example, for a pudendal nerve, you need a longer one, and in certain cases, you need to have a bigger surface area. For example, if you're doing hip or genicular nerves, you need a bigger surface area, so you better use a larger probe or longer probe if it's a deep structure. You also have a 15 centimeter probes. They are 14 gauge, triangular tip, and they give you up to 15 millimeter the diameter of the snowball. And this can be used also for structure that you need to ablate or freeze a bigger surface area. This is for SI joint. They have a specific probe. It's usually 15 centimeter long, 14 gauge, and have 2 freezing points. So the cryo probes, you can be for the needle and triangular tip, you better be more parallel to the nerves, while the radius tip, you can be perpendicular to the nerve since it's project outwards. Same concept as the cryoablation, the cooled radiofrequency ablation. This is a different system. Again, the one on the left that we can use it, it's more portable, and you can use it for superficial structure. There's other different systems that we have been used. I remember when I was a fellow in Cleveland Clinic about 12 years ago, we had that machine that was about 30 years old and it was still functioning. So there's different systems here in the market depending on what you prefer and what are your uses. So the steps for performing cryoablation: the target area is cleansed with chlorhexidine and draped. You typically use an angiocath 18 or 21. You use that as an introducer for the cryoprobe through the skin and sub-Q under ultrasound, fluoro, or CT guidance. And this is kind of a picture of the probe as it advances using ultrasound in plane technique. And typically you have, like you use radiofrequency ablation, you need to do both sensory and motor stimulation. And typically for sensory stimulation for accuracy, the lower you get it, you get the stimulation along the distribution of the nerve, you interact with the patient, and you should get it below 0.5 milliamp to be accurate. While usually motor stimulation is for safety. So you want to be, you don't want to have any motor stimulation. So you do it for safety. And you adjust your probe accordingly if you get motor stimulation. So the steps after you do the sensory and the motor stimulation, you activate the cryo probe for 1 to 3 minutes at the lower temperature. And then you have a cycle of defrosting for 30 to 40 seconds. And you can repeat that cycle 1 or even 2 times. At the end of the second freeze and thaw cycle, the probe is removed, and you can repeat the probe at an additional 2 or more levels depending on the patient's tolerance to pain. So I'm going to talk about it quickly because we're running out of time. Case 1, that's a true case that came to me from actually a different country for pelvic pain, pudendal neuralgia. She's 58-year-old with 8-year history of anal and perineal pain. Was told she had anal fissure. She has 2 anal surgery. The pain had got worse when she sits for a long time. As she has also perineal pain, difficulty with urination and defecation. Tried different specialists in the UK and in her home country. They tried Botox of the anal sphincter, pulsed RF of the pudendal nerve, pulsed RF of the sacral luteus in the UK. She has marginal benefits. Presented to me for second opinion. We did perform cryoablation of the pudendal nerve under fluoroscopic guidance after she had short-term relief after diagnostic pudendal nerve. So this is a picture of the ischial spine here, this structure. Typically, you need to do a caudal tilt and you oblique it until you can see that triangle. This is the ischial spine. And this is typically your target where the pudendal nerve runs, and where my arrow is. So the steps is you prepare the buttock and drape it in a sterile fashion. You do the skin anesthesia of the respective injection site, as I showed you. I used a 14 gauge cannula. I used it as an introducer, and we at the target area, and then I slid the cryoablation probe. I used a 9 centimeter, 21 gauge long, was introduced to the cannula under fluoro guidance, and slowly inserted, directed to the ischial spine under fluoroscopic guidance. After negative aspiration, I did a sensory stimulation, and the patient confirmed the feeling of the stimulation over the perineal area. After that, I did motor stimulation. There was no motor, and then we start, you know, the cycles of cryo with defrosting. We repeated that on contralateral side, and patient did very well. Again, I followed this patient up. 90% pain relief was achieved at 1, 3, and 6 months. Patient only takes tramadol and has been off all other opioids. The pain disability index for this patient went down from 67 to 9, marked improvement, and the perineal pain was negligible. She has moderate rectal pain, so we did a ganglion power block after that. Overall, the patient has much improved after 6 months. And this is the probe, and this is the probe, the position of the probe near the ischial spine. The second case is cryoablation of intercostal nerve, ultrasound guided, 35-year-old female with left-sided chest wall pain after successful lung transplant. She's 9 months after lung transplant with uneventful course. She has persistent chest wall pain over the left side, T6, 7, and 8, intercostal nerve distribution. Tried conservative treatment. We did T6, 7, and 8 intercostal blocks with temporary relief, but good relief. So we schedule a patient for cryoablation of those 3 nerves. And we put the cryo probe between those, you know, those 3 layers. And this is a picture of the cryo probe. It's hard to see here the snowball, but you can actually live see the snowball or the cryo lesion as you do it live. So the patient was put in the prone position. The left thoracic and posterior wall, chest wall areas were prepped with chlorhexidine. We used the ultrasound to identify the ribs, the intercostal nerve bundle, the pleura. We used their 14 gauge endocath as an introducer, and we used a 21 gauge 9 centimeter cryo probe, which was slowly advanced using an in-plane approach. And you can see it. You have to be very careful for those cases, because sometimes when you try to get the cryo probe to the endocath, if you go very fast, you can get the pleura. So you have to be very cautious, and you have to keep all the pleura in your visual field, the ribs and the intercostal bundle. So after we got too close to the intercostal bundle, we start the sensory and motor stimulation. And then after we make sure there is no motor stimulation and sensory stimulation was achieved, and we had good distribution along the intercostal nerves, we did 2 cycles of cryoablation with 2 cycles of defrosting. As you can see here, the patient was followed up after that. She had 80% pain improvement with no complication at 1, 3, and 6 months. There's still moderate parasternal pain, which was relieved by a parasternal block. Overall, PDI went down from 54 to 14, and the patient is doing much better. So cryoablation versus RFA, or radiofrequency. Well, each has its uses and advantages. Conventional RFA is more practical and effective for medial branch RFA, for example. For the spine in general, I prefer to use conventional RF. For the joint, you can use the conventional or cryo. If your target sensory branches such as genicular RF, you can use RF. You can use cooled RF if you need the bigger lesions or other types of like the venom needles, the limbus. There's different nimbus. There's different systems that you can use to have a bigger lesion. You can also choose to use cryoablation. the hip articular branches, the shoulders. I can use either RFA or cryo depending on what do we have and practically what's available, and also cost effectiveness play a role in that. If you have mostly a sensory nerve that is targeted, for example, intercostal nerve, pudendal nerve, I prefer to use cryo over conventional RF to avoid the denervation, hypersensitivity, and other problem. You can make an argument to use a pulsed RF. In that case, you need to do multiple cycles. In the US, pulsed RF is not reimbursed and is frowned upon. But again, it's your preference. But cryoablation can be a very good option for those cases. So in conclusion, the cryoablation can be safely used if the nerve is in close proximity. One of the advantages as well is it can be used if the nerve is close proximity to the AICD. If you have an AICD, you can either use a bipolar RF or you can use a cryo, but if you use a conventional RF, you have to be very careful because you can damage the pacemaker. Proper technique and ultrasound fluoroscopic scale is essential. You have to know what you're doing, this because otherwise you can cause, remember, no harm for the patients. Cryoablation used primarily for sensory nerve ablation, although sometimes they can be used for mixed nerve in certain scenarios, as I said, the suprascapular for post-stroke pain. In very special scenarios, cryoablation of a motor nerve can be used. And this has been described in a few centers when you actually target the motor nerve for patients with spasticity like cerebral palsy, and you cryo those motor branches to relieve the spasticity. So there are a lot of uses that can be used out the box that can be promising in this field. And this is a picture of our hospital, and thank you, everyone.